TopMedTalk. So hi, it's Monty Mythen here, Editor-in-Chief of TopMedTalk, and we're doing a little special at the moment. We're going to have a chat with an old friend, Dr. Tim Miller, who is an anesthesiologist from Duke University Medical Center in North Carolina in the USA. There's a number of different reasons we've got Tim on the line. One of them relates to the June edition of Anesthesia and Analgesia. I'll come back to that in a second. And then a nice series of meetings, two of them at Duke University Medical Center in the USA next week, followed on by a meeting in Orlando. So Tim, you're in North Carolina at the moment, in Duke?
I am. I'm in my office in the Department of Anesthesiology at Duke, looking out at the beautiful sunny weather, about 30 degrees centigrade. Humidity's just starting, so it's very nice.
Well, it's not quite like that here, but you're an expert, Tim. You know, not rugby. I think cricket could be played today, although the light meter might be out. So, diving straight in, the June edition of Anesthesia and Analgesia is literally smothered in the perioperative quality initiative, starting with the front page. So you must be delighted with this, Tim. It's got the front page talks about the latest POQI papers, perioperative quality initiative, and then within it, we'll go through the different bits at the moment. There's lots of different articles, so tell us a little bit about that. Yeah,
so the edition really highlights POQI 2, which was a conference that took place approximately a year ago now in Stony Brook, New York, where we discussed three topics, which was perioperative nutrition, postoperative ileus, or as it was redefined, postoperative gastrointestinal dysfunction, and patient-reported outcomes within enhanced recovery pathways. And these three articles were all published in the June edition, along with accompanying infographics, editorials, and, as you say, some cover art. So it's great to see it in print.
Cover art is what one might anticipate. We've got some carers there. We've got a patient in the centre as it's patient-centric, and then there's some diagrams that represent infection and wounds, and then activity and nutrition and overall well-being. And if I jump inside, as you say, there are two infographics. The first one is entitled No Guts, No Recovery, A Rational Approach to Postoperative Gastrointestinal Dysfunction. And it starts off with the iFeed score.
Yeah, I hadn't seen this infographic before the journal was published. And this infographic really talks us through the iFeed score. And when we had this POQI, the group were initially charged to write a manuscript around postoperative ileus, and one of the things that they discussed very early on is there's no consistent definition of postoperative ileus. So they really tried to think about this as a group and came up with this iFeed score, which is new. It needs validating. Literature and studies are in progress to do that, but it's a new way of trying to define postoperative gastrointestinal dysfunction based on those five letters, I, F, E, E, D, being intake of oral diet, feeling of being nauseous, whether you actually have vomiting, emesis, what your exam shows, and the duration of your symptoms.
So I for intake, F for feeling, E for emesis, E for exam, D for duration, spelling I feed. So that defines exactly how to do it. And then the infographics, we're not going to go through it all now because we don't have the time, but we will come back to this. The second one is a large stomach talking about how to prevent postoperative GI tract dysfunction, which has multiple elements within that. And then it's still going to happen in some patients, no matter how hard you try, no matter how brilliant your enhanced recovery program is. And the last one then is how to treat it, starting with our old friend that we've been trying to take out of our patients, the nasogastric tube. So nasogastric decompression if a patient truly does develop postoperative GI tract dysfunction. Have you ever had an NG tube down, Tim?
I have, actually. I did some studies when I was a medical student to get some extra cash when the H2 blockers were just coming in. So I spent some nights in Birmingham Medical School with a nasogastric tube in, and they're very unpleasant.
Very unpleasant. So I've done not exactly the same experiments, but and no one paid me. I swallowed nasogastric tubes for research purposes as well, and it really, really is one of the most unpleasant things. Myself and Tony Senegor, who were in this group, were reflecting on the fact that the only time you see a patient who says thank you for a nasogastric tube is when they really have postoperative GI tract dysfunction. It's the only time the tube goes in and they look happy to have a nasogastric tube is quite an interesting litmus test. I think that's a fair comment.
Yeah, I agree. And I was just going to add a little bit of background on these three articles. I think it's important to perhaps discuss where these subjects came from. And this POQI was sponsored by ASA, the American Society for Enhanced Recovery. And before this POQI, we asked the ASA board the three subjects they would like the POQI to tackle. And these were by far the three subjects that came at the top of the pile. And one of the reasons particularly I was pleased that we did this POQI on postoperative GI dysfunction is a lot of the literature on enhanced recovery assumes that it's obviously going to be good for patients and it goes swimmingly. And we obviously hope that's the case, but I think it's also important to have a rational approach when you do get a post-op ileus. And as you already said, complications of course still happen, but it's how you manage those complications. And I think this article addresses that very well.
And I think many people have reported, because a key element of enhanced recovery with GI tract surgery in particular is not putting in a nasogastric tube until you need one. The unintended consequence of that is the reluctance to put a nasogastric tube in when you need one. And we have seen some people have some disappointing results because they've just held out for too long. So that's very useful. So the next infographic, turning over the page 1800 in the June edition of Anesthesia and Analgesia, is finding the way to improve surgical outcomes, but the way is spelt W-H-E-Y. Why is that, or way is that, Tim?
So this relates to the POQI that was on perioperative nutrition, and this is the article that's probably received the most press so far. There's been a lot of tweeting about this article, and perhaps really trying to say that nutrition really should be an important part of any major surgery within an enhanced recovery pathway. And the way comes from the fact that this group tried to emphasize how important protein is, and the fact that protein, or whey protein, W-H-E-Y, is probably more important than overall calorie intake for patients undergoing major surgery, both preoperatively in patients that are shown to be malnourished, and definitely almost for all patients postoperatively.
And I think, we've interviewed Professor Paul Wishmeyer on 2 occasions about this article, and the key thing, I think, which many of us recognise that we weren't doing, is the nutritional screening. So about a week or more before surgery, a nutrition screen that's based on BMI, weight loss, whether the oral intake is down, and a measurement of albumin. So it looks very, very simple. Now, are you doing that routinely now in your organisation,
Yeah, we're
Tim?
doing this routinely. Exactly, and we're doing this exact same nutrition screening. And as you say, the key is simplicity. This is a screen which has been modified from an existing nutrition screen to make it particularly relevant for perioperative patients. It's very easy to do, and it can take just a couple of minutes to screen every patient undergoing major surgery.
And then if we move on through ANA, there's a series of editorial. There's one about reporting outcomes from Lee Fleischer and Cliff Coe. There's another one commentating on the nutrition articles from Mike Scott and Robert Martindale, following on from that. And then, yes, another one about standardization of the classification of impaired postoperative GI tract dysfunction from Elizabeth Wick and Christopher Wu. So some really big hitters in there commenting on the articles. And they all seem to be very reassuringly complimentary as well. Is that how you read them, Tim?
Exactly, yeah. Again, I hadn't read them before, and one of the things we did request from the journal was that all the editorials, we would like to have them with one surgeon and one anesthesiologist. All the manuscripts themselves were written by a combination of perioperative nurses, anesthesia providers, surgeons, and so the whole perioperative team. And again, the editorial was written by an anesthesiologist and a surgeon. And I think this is very important, and one of the key things that ASA, the American Society for Enhanced Recovery, is trying to bring to ANA with our new collaboration is that multidisciplinary nature and the inclusion of the first ever surgeons on the editorial board of ANA.
Excellent. And you're the upcoming president of the American Society of Enhanced Recovery. Julie Thacker, I think, is the current president, and TJ Ganhill, we'll refer to in a second, was the founding president. So all involved in that endeavour. So as we move forward through the journal article, getting to the meat of it now, coming up on page 1867, there's an advert for a meeting that's coming up before the American Society of Anesthesiology in San Francisco, Friday, October the 12th. That looks excellent, called Perioperative Quality and Enhanced Recovery Conference. And that's in collaboration with the American Society of Enhanced Recovery, the Perioperative Quality Initiative, POQI, and Stony Brook Medicine, which is where Professor T.J. Gann is the chair, and, of course, evidence-based perioperative medicine. Then we go into the details of ASA, the American Society of Enhanced Recovery, and then we come to the 3 articles. So the articles are there. Again, more infographics provided by the Perioperative Quality Initiative. Are they up on the website yet, Tim, the infographics from POQI?
They're just going up as we speak. They should be up in the next couple of days.
And they're all open source. If you don't, for some reason, have access to the ANA articles, they're open source directly from POQI.org. Is that correct?
Correct.
And the first article I see here, which is a special article written by T.J. Gann, Mike Scott, Julie Thacker, Tracy Hendrick, etc., with you as the senior author, Tim, along with Bob Thiele, as part of it explains the POQI process. So figure 2 actually goes through the flow. If people are still confused about this modified Delphi technique, there is some detail there about how it's conducted. And then on to the main article. So really encourage people to, it's quite a lot of reading to do there, and quite a lot of references, but excellent, 3 excellent articles. Any final comments on that, Tim? Because we're under time pressure now, and I want to get to your other exciting news for the next week or so.
No, just please encourage people to read the articles, or if not, look at the infographics and the editorials, and hopefully we'll get the next POQI published soon.
Excellent, and don't hesitate to feedback, so people can feedback their information to the journal or via the various different players directly. So, Tim, coming up at Duke next week, you're running a special Extreme Everest conference. Is that right? Under the guise of the Morpheus Consortium.
Exactly. The Morpheus Consortium is a collaboration between Duke University, School of Anesthesia, with University College London and the University of Southampton. And obviously, as you know, you have been very involved from the start in Extreme Everest with Professor Mike Grocott, and we're delighted to have the Everest team come to Duke next Thursday, which is June the 14th, for Extreme Everest Symposium, which is going to be fantastic.
And it's almost a full day going through all of the results and all of the different various sections to date, and then culminating in the evening with Mike Grocott giving a plenary lecture that includes information about the summit, etc. Now, the TopMedTalk team will be out there because our plan, unless there's a major hitch, is to live stream so people around the world can listen in, which is all part of the Morpheus Consortium's mission statement to make high-quality education as accessible and affordable as possible. So is that still the plan, Tim? We've got a green light to try and live stream that?
Absolutely, and I think we're going to have a good number of attendees at Duke, and obviously, if we can live stream, we can really open this out to a much larger audience. So anyone that is interested in this subject, please see if you can listen in. I think it's a great program. You can see the program on the Duke Anesthesiology website. It's anesthesiology.duke.edu. And it'll be starting at 1 p.m. on next Thursday, the 14th. And that's Eastern Standard Time in the US, and continuing on till about 8 p.m. in the evening.
And we're planning to then stream that for a period of time afterwards, so whenever people pick it up, if they go to the TopMedTalk website, it should be barn door clear, and it's all freely accessible, how to click on in there. I think if you subscribe earlier, which is open now, then you'll have an easier route into all of that. But whether you come at it via the Duke Anesthesiology website, the Extreme Everest, spelt Extreme without the E, Everest website, or the TopMedTalk website, they'll all bring you into that opportunity. And I think there's a good crowd coming now, Tim, and there's perhaps a glass of sparkling wine in the evening or something going to be had as well.
Exactly, some bubbles and some hors d'oeuvres for Mike's plenary talk in the evening, which I'm very much looking forward to.
And then straight on from there, the team are going to be joining another perioperative quality initiative. But this one's a little bit different, isn't it? So you've got a bunch of applied human physiologists in town as a result of the Extreme Everest endeavour, and some others are coming along to discuss a particular topic or two. Tell us about that.
Yeah, we really wanted to discuss the topic of fluid physiology, which is obviously we deal with as anesthesia providers on a daily basis, and as we have a group of physiology experts in town, as you mentioned, we thought it was an ideal opportunity to have a POQI on this subject. And so we're going to have two groups, one looking at really fluid responsiveness and the physiology of fluid responsiveness, and the other group really examining sort of body, water and electrolyte content and the different compartments of the body. And we've all learnt this physiology when we went through medical school, but really trying to do a practical document reviewing the latest evidence in terms of physiology and making practical consensus statements and recommendations for the practicing anesthesia provider.
So when we say fluid responsiveness, Tim, because not everybody listening is in our field, it is when we are giving intravenous fluids during, for example, a major surgery or some trauma, when we believe the patient may have a deficit in intravascular volume. It's judging, broadly speaking, how they respond to the fluid we give them.
Exactly. So it's something that we do during every case. We're giving intravenous fluid, but how we monitor, measure, and respond to the results that we get from that fluid challenge still a lot of variation. So we really want to get a group of experts together to review this topic and review both the basic physiology and the clinical work that's been done around assessment of fluid responsiveness.
And who's chairing that group, Tim?
So that group is being chaired by Greg Martin,
yep,
who's an intensivist at Emory, and Paul Marek, who's very well known in this field, is co-chairing that group.
Well, there'll be no shortage of opinions there, and I'm guessing that the rest of the group will have plenty to say too. And Group B, tell us a bit more about the chairs of that group.
So Group B is being chaired by Tom Woodcock, who is very well known for some of his writing on particularly the endothelial glycocalyx and the body compartments, the compartments of the body in terms of fluid management. He's from the University of Southampton. He wrote an excellent article that many of you may have read. If you haven't, I encourage you to do so, by Woodcock and Woodcock, with his son, who is also coming to the POQI, which was in the BJA back in 2012, on the endothelial glycocalyx and revised Starling equation. And it's a classic manuscript, and we're going to be discussing many of these topics in this POQI, and perhaps delving into the latest controversy, which was the fact that the people thought the interstitium should be a new organ of the body a few weeks ago. Some of you may have seen this made the press. And I look forward to those discussions.
Well, there's plenty of it, and as we've decided there's no third space, we need to put something in there to talk about, don't we? So the third space is dead, but the interstitium is alive and well. So that's going to be great fun. And more outputs under the guise of POQI, but these are going to be slightly different because we're going into some unknown territory. We're identifying some known unknowns. Are we going to have some recommendations from this, or maybe possibly some recommendations, but more research recommendations and more, we really should find out more about this.
Exactly. It's going to be mainly consensus statements around the physiology. And we never exactly know how the final product that's going to come from the groups. That's the joy of having the POQI conference. And there may be some clinical recommendations, particularly around fluid responsiveness, but it's largely going to be reviewing the physiology about how it applies to things that we do on an everyday basis.
And then finally after that, you're heading down to Florida to Orlando for, is it the 19th meeting from Duke in the perioperative space?
Exactly, the 19th annual Duke Anesthesiology Conference, Controversies in Perioperative Medicine, and that's all week from June the 18th to the 22nd, and really trying to, with both plenary sessions and workshops, go over a lot of the debates around management of patients undergoing major surgery, with lots of time for discussion, lively debates, workshops, and of course podcasts with the
TopMedTalk team. Yeah, so we're bringing a separate team out for that one, popping out to bolster that. So we'll be bringing that for certainly the first couple of days live to everybody, and we'll do a whole bunch of interviews there as well. So, Tim, thank you very much for giving us your time. You've got to head back into the operating theatres now to cover some cases. Any other news for us? How's the sport going in the... What do you make of the cricket recently? How about that one? You know a bit about cricket. So
I'm actually going to see the 2020 when I come over in July, which I'm very looking forward to. I've never seen a 2020 match. So I'm going to see Somerset, which is from my neck of the woods. I'm a Devon boy, so I used to go and watch Somerset in the days of Botham, Richards and Garner, which some people listening may remember. So, but I'm going to the new era of Somerset. They're playing Gloucestershire. So I'm looking forward to that. And I still try and keep up with the cricket.
So 2020 is like cricket, but exciting. I think is the...
Exactly. It doesn't take 5 days, more like 3 hours.
Exactly.
So the game's starting at 5:30 in the evening, and hopefully a sunny Taunton, and have a couple of beers and watch them hit a few sixes is the plan.
And your local old equivalent side, which is baseball, is the Durham Bulls. How are they doing at the moment? I don't know where your seasons start and finish. Are they doing all right? Have they bullied?
They have started playing. They play games on an almost daily basis, so it's difficult to keep up. I think we're taking the Extreme Everest crowd to watch a game next Wednesday. We're actually not going to sit in the stadium. There's a very nice bar which overlooks the baseball park, where you can watch the game and also have some food and a couple of drinks. So we're going to take them there to enjoy the Durham atmosphere.
Okay, so it's slightly elevated there, so borderline hypoxic. I don't know, what, about 300 feet above sea level or something? Okay.
Exactly.
Good to talk to you, Tim. TopMedTalk.
Nick Majerison here. Do remember you can meet the TopMedTalk team when we're going to be at the results of the Extreme Everest Symposium, June the 14th, live from Duke University in America. And of course, we're at all of the EBPOM meetings. Check out ebpom.org and find out how you can meet the TopMedTalk team.